everyone. Thank you so much for participating in today's webinar on the overview of breathing with muscle weakness neuromuscular disease. Today's guest speaker is Andrea Klein. Having earned a Bachelor of Science in English journalism with a concentration in public relations from Tennessee Technological University in 1996, Andrea has worked in the healthcare IT field for nearly 25 years. She is co-author of a chapter in the textbook Non-Invasive Ventilation and Weaning, Principles and Practice, 2nd edition, published in 2018. She served as Miss Wheelchair Tennessee 2017 and received the Lifetime Achievement Award at the Miss Wheelchair America 2018 competition. She founded Breathe with MD Inc. in memory of her middle sister, Cheryl Lewis, who died because of inappropriate care for neuromuscular respiratory failure. Andrea has a passion for educating others about breathing muscle weakness and the importance of medical self-advocacy. She developed and implemented Breathe with MD's Breathing Muscle Weakness 101 online course, which has enrolled nearly 250 participants in the last 2 years. Andrea lived with intermediate collagen 6 congenital muscular dystrophy and has used non-invasive ventilation since 2013 and mechanical cough assistance since 2014. Throughout the presentation, you can send questions at any time by clicking the Q&A feature at the bottom of the Zoom window. Andrea will answer the questions at the end of the presentation. Thank you so much for joining us, Andrea, and giving this talk. And with that, I'll turn it over to you.
All right. Thank you so much for that introduction, and thank you for having me here today. Obviously, I'm not a clinician, so my presentation is based on patient perspective. Specializes in the breathing issues of those with neuromuscular disease. I always like to start my presentations with a quote, and I wanted to share something that just drove home the point of how important it is that we're here today learning about this. And it says, despite the introduction of new techniques to manage respiratory involvement in NMD, it is still considered the leading cause of death in this group of patients. And I hear so many in the community tell me that, oh, I have such weak lungs or I have bad lungs, but it's all about the muscles. Respiratory involvement affects the respiratory or breathing muscles, those that are located between the ribs, known as the intercostals, and in the abdomen, with the largest one at the base of the abdomen being the diaphragm. It can affect the muscles of the upper airway, the throat or glottis, and the mouth muscles known as bulbar muscles. All of this impairs our ability to ventilate, move air into and out of the lungs. It's also important to understand the relevance of blood gases with regard to respiratory involvement in neuromuscular disease. The ability of the lungs to expand and take in oxygen, O2, and exhale the waste product of that air, carbon dioxide or CO2, becomes difficult because this process involves the use of muscles. So over time, what we find can happen is hypoventilation, underventilation. This typically is going to present itself during sleep. It can be subtle. We like to say it has a way of sneaking up on you. It can be gradual in onset, and initially you won't necessarily experience symptoms every day. Often these symptoms can be attributed to something else or not even recognized. I have spoken to individuals who have had evaluation and testing and found out that they need breathing support, but they deny having any symptoms at all. So the symptoms I'm sharing on this slide, this is not an all-encompassing list. These are just the things that we hear commonly throughout the community. The first one, anxiousness or shortness of breath when lying down. This is something that my middle sister, Cheryl, she experienced, and she never thought of it as a indicator that she was having problems with her breathing because she knew that she could not independently rise from a reclined position. So she thought, well, if my house were to catch on fire, I'm not going to be able to get up. So she just assumed that it was sort of like a panic attack, not a signal that anything was going on with her breathing. Restlessness while trying to sleep, frequent awakenings after short periods of sleep, those are things that people without neuromuscular disease can commonly have. Being tired after a full night's sleep, maybe you used to be able to get 6 hours or 7 hours of sleep and feel fully rested. Well, now you find yourself needing 9, 10, maybe even 12 hours of sleep. This can be an indicator that something is going on with your breathing during sleep. Awaking with a headache that goes away in minutes, particularly after one is seated upright. Recurring respiratory infections, that's one that a lot of folks overlook. Increased fatigue, unexplained daytime sleepiness, and periods of microsleep, nodding off. I personally experienced this not before I was on breathing support for sleep, but at a time when my settings needed to be changed. I was in a very rousing meeting with heated debate, something that I would never think that I would nod off during, but I found myself fighting to stay awake. And thankfully, I knew and was able to act on that symptom. Difficulty waking up. Do you have to set 2 or 3 alarms to be able to wake up on time? So if you suspect that you might be experiencing hypoventilation, this would be an indicator that you need to seek an evaluation of your breathing function. There are some things that are key to ensuring positive outcomes with that process. The first of which is to use medical self-advocacy, speaking up for oneself or on behalf of a loved one. This is something that maybe you won't initially have to do this, but throughout the duration of your journey with breathing muscle weakness, there will be times that you absolutely have to use medical self-advocacy. This can be sort of difficult for some of us, particularly those of us that are shyer and, just feel like this is outside of our comfort zone. And a key component to this is being knowledgeable, at least having a core set of knowledge about what you need to advocate about. So that is what we're doing here today, hopefully giving you some initial information that you can take and use to learn more. See a clinician who specializes in neuromuscular breathing weakness. I know sometimes that can be easier said than done, and sometimes it's based on our geographic location. Many of us have to travel hours. I travel more than 3 hours for my care team. I know folks that have to get on a plane and go across the country to see someone for their neuromuscular breathing weakness. Sometimes it's just not practical for a variety of reasons. So some have been successful partnering with a less experienced clinician. And I say partner because if they're not informed about neuromuscular breathing weakness, then that really places the burden back on the patient to sort of do a knowledge transfer, so to speak, sharing medical literature. And of course, the other side of that is you need a clinician who doesn't have a really big ego and who is accepting of the fact that someone with a rare disease may in fact know more about their condition than the physician does. So there is the possibility of being successful with that, but sometimes individuals have to change clinicians multiple times until they find that right one that is going to partner with them and maybe even have the initiative to research and learn about this on their own as well. So the evaluation process, what that looks like, you're going to want to ensure that they do pulmonary function testing, PFT. Sometimes clinicians use non-digital spirometry. That's okay too. You just want to make sure, and this is a an opportunity for self-advocacy. You want to make sure that they do the measurements while you're both seated and supine, lying down. Dr. John Arbach, who is a pioneer in the non-invasive ventilation space, he has a website, Breathe NVS, and he points out a lot of management errors, so to speak. And one of them is lack of doing PFT both seated and supine. So seeing a difference between those two positions that's greater than 7% is abnormal. Differences that are greater than 30% with supine vital capacity being lower, that's caused by diaphragm weakness, and it usually causes orthopnea, the term that means the inability to breathe when lying flat. And this just tells your clinician it's time for them to start you on non-invasive ventilatory support during sleep. So there are some key measurements in PFT. These are certainly not all of them, but ones that you want to ensure are included for diagnosing hypoventilation and for determining qualification for insurance to cover mechanical ventilation in the US. So forced vital capacity, FVC, that's where it's your most forceful exhalation that you can take after your deepest inhalation. Inspiratory capacity is your deepest inhalation you can take after your most forceful exhalation. And then these last two, these are measures of muscle strength. These are commonly left off, especially by physicians that are not experienced with breathing muscle weakness. So maximum inspiratory pressure and maximum expiratory pressure, MIP and MEP. Polysomnography or sleep study, again, there's an opportunity for self-advocacy. Oftentimes, all they do is measure your oxygen saturation. But remember that blood gas exchange is such an important component of respiratory involvement. And so you want them to also measure your carbon dioxide level during sleep. There are painless ways for doing this. Capnography measures it through your exhaled breath. Transcutaneous CO2 monitoring measures it through sensors that are placed on the skin. And some NMD specializing clinicians today do not order sleep studies for adults. They recognize that for some of us, these facilities that do this, even hospitals, even specialized centers, they are not accommodating of our needs. Sometimes they don't have staff that can assist with dressing, going to the bathroom, getting in and out of the bed. And also, they don't always make accommodations for caregivers to come along with us to assist with those things. So, in some cases, you might have the alternative of an at-home sleep study, or sometimes it's called an overnight oximetry. But again, you can request CO2 monitoring. Now, that's not something that you can just show up for the sleep study and say, hey, I want this done, or when they deliver the equipment and show you how to use the at-home sleep study equipment. That's not the time. This would need to be discussed in advance with your clinician, because that would have to be part of the order for this. Many years ago, I believe in 2007, MDA USA in their Quest magazine published an article called Not Enough Z's. And a couple of months ago, I checked and it was still out there in their archive. So I encourage you to look for that. But they interviewed a lot of experts in neuromuscular breathing weakness, and Dr. John Arbach was one of them. And he questions the usefulness of polysomnograms for people with muscle diseases, because the test interprets all abnormalities as central or obstructive apneas rather than weakness, especially when read by physicians unfamiliar with neuromuscular disease. And this is what we hear so often too with Breathe with MD Inc. Basically, what happens is our breathing can be so shallow that the equipment does not pick it up, and it sees it as a stop in breathing, when in reality, it's just our weak muscle effort. Dr. Bach goes on to say that this misdiagnosis then leads to improper treatment. All symptomatic weak patients need full nocturnal inspiratory muscle rest with very high span BiPAP or use of portable ventilators to fully rest the muscles, not CPAP, oxygen, or low span BiPAP. Treat the patient, not the polysomnogram. So today we just barely scratched the surface of the evaluation topic. There's so much more to learn on that. I encourage you to go to breathewithmd.org and select our evaluation link. And we go into a lot more detail there, and there are 4 subpages on those topics that you can read more about. So from this point forward, we're going to look at management intervention. So for respiratory involvement, it's something that we can't just completely eliminate. We manage it. And so this article, published in 2019, points out that the aim of respiratory management of patients with NMDs is threefold. You've probably heard of ventilatory support. The second component here is cough augmentation. I find a lot of folks are not very familiar with that. And then lastly, lung volume recruitment. A lot of folks have never heard of LVR. So we're going to go into a little bit of detail about those from this point forward. But say you've completed your evaluation process, you've had your testing, and you've learned that now you need to start mechanical ventilation. Unfortunately, a lot of folks end up seeing someone who maybe does all of the right tests, but they don't interpret the test results appropriately. And so, like our quote from that Quest article said, sometimes the wrong things are prescribed, sometimes nothing at all. So I like to share these guidelines to kind of help you in the event that you're seeing someone who doesn't understand this. So potentially, maybe you already qualify for this, but your clinician has not offered it. So these guidelines are based on CMS, Centers for Medicare and Medicaid Services, National Institute for Health, and Care Excellence guidelines. They're 4 objective criteria that can be used to guide your clinician in when it's appropriate to start you on non-invasive ventilation. So forced vital capacity of less than 50% of predicted, measured during that PFT while you're either seated or lying down. Maximal inspiratory pressure of less than 60 centimeters of water or sniff nasal pressure of less than 40 centimeters of water, measured upright or supine. Then an arterial blood gas of greater than 45. And then lastly, an overnight nocturnal desaturation of less than 88% for 5 minutes. That would be during a sleep study or overnight oximetry, a home sleep study. So the thing to understand here is that it's if you meet any one of these criteria. So contrary to what some people think, you don't always have to have a sleep study. You could simply have a PFT and show that your forced vital capacity is less than 50% of predicted, and then you would qualify as long as your clinician documents this well in the visit notes. And also, too, if you don't have Medicare or Medicaid, since that's who CMS developed these guidelines are often, well, not often, but usually, I should say, followed by private insurance companies as well. So non-invasive ventilation, abbreviated NIV, this is the gold standard starting point for us. It requires an interface, which would be a mask, such as a full face mask, an oronasal one, a nasal mask, or nasal pillows. And you can see the nasal pillows featured at the bottom. Those just kind of tuck just inside the nostrils. I didn't list nasal prongs. Those are starting to gain popularity. Those usually go a little bit deeper into the nose, but those get connected to tubing to deliver air from a respiratory assist device, like a BPAP, some call it a BiPAP or a bilevel, or a portable home use ventilator. There's also the option of mouthpiece ventilation, and with mouthpiece ventilation, you would need to use a portable ventilator, specifically with a volume cycled mode. Biphasic cuirass ventilation, BCV, you can see a gentleman on the slide wearing that. It's a form of negative pressure ventilation, and I have to say that I don't know very many adults that use this for sleep. Those that have tried it did not find it to be very comfortable, but some do use it for daytime breathing support when their condition progresses and they need that. Some within the pediatric population also use the BCV system. So when we talk about non-invasive ventilation, I always want to make sure people understand the difference of CPAP. Now, if you Google non-invasive ventilation, chances are you're going to find that CPAP is listed. But for those of us with neuromuscular disease, it is usually contraindicated. And that's because it acts like an air splint to keep the airways open. But remember, that's really not our primary issue. We may have some degree of apnea, maybe obstructive apnea or a floppy airway, but our primary issue is that we don't have the muscle strength to get deep enough breaths in and push those out. And CPAP offers one continuous positive pressure. And if that is turned up high enough to fill the lungs, usually it's too difficult to exhale against if you have weakened breathing muscles. So when there's respiratory failure with increased CO2 in the blood, usually this alone is inadequate. And I say usually because usually when I do these talks, someone will chime in and say, but I've used CPAP for 15 or 20 years and I'm doing okay. Sometimes when we look closer at those folks, we learn that they don't have very weak respiratory muscles. So again, just wanted to point out that difference because I know there's a lot of confusion surrounding CPAP and a lot of folks get prescribed that and have to self-advocate and let their clinician know that this is not what's recommended. So contrast that with bi-level ventilation, which has two different positive airway pressures, an IPAP, inspiratory positive airway pressure, and EPAP, expiratory positive airway pressure, that is much more reduced, what we exhale against. The span is the difference between those two values. You subtract the EPAP from the IPAP, and then that tells you what kind of breathing support is being provided. For example, an IPAP of 18 and an EPAP of 4, that would be breathing support of 14 centimeters of water. So again, bi-level ventilation is what assists in moving air into and out of the lungs. And if we still have some degree of apnea, such as obstructive apnea, it will address that as well. So invasive ventilation is an option, and this is where air is delivered via tubing from a ventilator through a tracheostomy, a surgically inserted hole in the windpipe or trachea. It's usually a consideration for those who are using 24/7 non-invasive support. Maybe they can't get a break away from their mask ventilation because perhaps they're not able to seal their lips on a mouthpiece, even the smaller, the straw mouthpiece during the day. Some people just struggle with finding a mask that's comfortable. Some have serious claustrophobia, and this is a choice that they make just to go straight to invasive ventilation. If you are considering that, there are some things that you should be aware of to make an informed decision and planning. It's something that you would want to proactively do as opposed to be in an emergent situation and have to resort to that in a life or death matter. So potential lengthy hospitalization and or skilled nursing or rehabilitation center stay, this is going to vary widely from person to person, but I have seen folks in the community who have been admitted, say, in late November, and they've not gone home until April or May. It tends to be a shorter hospitalization. The younger people are, but not necessarily. Sometimes there are challenges presented based on the new and or increased care needs, struggles with getting approvals for the in-home care that's needed. There's trach care competency that's going to be required before discharge home. There's just a certain amount of things that you and at least one caregiver are going to need to know about, things that need to be managed on a weekly basis, monthly, and things that you need to be aware of for emergencies. There's a potential increase in secretions, mucus coming up from the lungs that is requiring suctioning. And some don't experience that before tracheostomy and find that this is, kind of a shocking development for them. And if they're not able to suction independently, then sometimes they're in a situation where they have to have someone with them at all times. Um, and often that is something that's temporary. But some folks we find they just have a lot of secretions, pretty much indefinitely. Potential increased risk for infection, loss of speech, although that's less likely today with the advent of speaking valves and speech language pathologists that can come in and consult. And there's also the potential of swallowing and eating difficulty, which can be temporary, as well as that loss of speech. But the challenging thing is that no clinician can tell you in advance, are you going to have these challenges or not? And I really recommend that folks that are looking into this meet others who have a trach. Ask all those questions, get a feel for what their experience is, and that can be really beneficial in making that decision. Regardless of whether you're using invasive ventilation or non-invasive, there are benefits to mechanical ventilation. Maintaining and or improving the oxygen and carbon dioxide levels in the blood, kind of maintaining that delicate balance of those two, resting the respiratory muscles. That's the one where often we don't realize that what we're doing during sleep can have such an impact on how we feel during the day while we're awake. Decreasing the work of breathing, inflating the lungs more fully, improving sleep quality and breathing during sleep, preventing and avoiding hospitalizations for respiratory complications, and best of all, improving quality of life and survival. So cough and neuromuscular disease, it's one of these things that I think a lot of us take for granted. We may not realize how weak our cough is until we're in a situation where maybe we've gotten a virus, we've developed a lot of secretions, and we see just how difficult it is to cough and how tiring it can be. It is what helps clear inhaled foreign materials, aspirated foods and or liquids, and retained or excessive mucus from the airways. Our muscles that are used to cough, they weaken and they can get contracted, leading to something known as cough insufficiency. A lot of us just don't realize what the risk is of a weak and or ineffective cough. And this quote comes from an article that's actually 25 years old. And I still share it today because sadly, I believe this still stands to be very accurate. This year in particular has been a very difficult year for the community, and we still see this happen all of the time. Approximately 90% of episodes of respiratory failure, referring to acute respiratory failure, because a lot of us live with chronic respiratory failure and we just manage it through these interventions that we're discussing. Within patients with neuromuscular disease occur during otherwise benign upper respiratory infections because of the inability to clear the airways. What they're referring to when they say benign here is the common cold. Most of us have known or maybe even personally experienced having a cold that rapidly escalates to pneumonia simply because of the difficulty we have in clearing our airways. And so what do we do about that? Well, we work with our clinician to develop a secretion clearance plan. The goal is to remove or clear that mucus from the airways as quickly as possible. The longer that stays there, the more there is time for bacteria to rapidly multiply and for this to escalate to pneumonia. So one of the options we have is manually assisted cough. Generally, this involves the use of a caregiver to help us. It's achieved by either or a combination of a manual Heimlich/abdominal thrust and manual compression to help make an exhaled breath stronger. You can also do this, or some can, through a self-induced thrust to one's abdomen and or chest from a stationary object like a table or a large piece of furniture. But most of us find that mechanically assisted cough is more comfortable and more effective. In medical literature, it's often referred to as mechanical inexsufflation, MIE, or a lot of us simply call it cough assist device. It delivers deep insufflations, positive pressure breaths, followed rapidly, depending on the settings that are enabled on the device, by deep exsufflations, negative pressure breaths. Think about a vacuum cleaner for your lungs. The air is delivered via an oronasal mask that covers both the nose and the mouth, a mouthpiece, or a tracheostomy with the cuff inflated. These devices provide the same flows in both the left and the right airways. They can be effective at reaching deep within the lungs when suctioning is not. And some of the devices today include high frequency oscillation, sort of a vibration that comes with the air that's being delivered. And you can even turn that on for the air that is being reversed back out. So the benefits of mechanically assisted cough, those immediate ones, are that we gain a stronger cough during use. It allows us to get those secretions, that mucus, up and out. It can prevent infections. Most of us that use these devices can tell you that we've never been hospitalized because we're using this to prevent pneumonia, or if we get pneumonia, to better manage it in the home. The device can also increase oxygen saturation because when our lungs are filled with mucus, that can block the space where oxygen can go. And once we get that out, we see an increase in our oxygen saturation. Long-term and daily use is something that over a period of months or more than a year, we can see that it will stretch our chest wall muscles. And some of us see that we get deeper breaths when we're off of our ventilation because of that stretch. So who needs mechanical cough assistance? Again, let's talk about medical self-advocacy here, because too often people go in to ask their clinician about this and they're told, well, I listened to your chest. Sounds clear to me. You're not coughing today. And so they leave with a clinician who's not supportive of getting this for them. But it's not about having a clear chest and not having a cough today. It's about learning what your cough function is. And Dr. Hank Meyer, he published a book in 2023, actually on pediatric neuromuscular disease, but he shares about adolescents and adults as well. And he points out that vital capacity, that measurement we talked about with regard to PFT, maximum expiratory pressure, and peak cough flow, these are the commonly used markers of cough function. So these are the things that you want your clinician to prove to you do not show impairment if they're saying you don't need this device. So in adolescents and adults, cough function is considered impaired when vital capacity is less than 50% predicted. You may recall that's the same criteria that was listed with regard to starting mechanical ventilation. So most of us at the same time that we're getting our nighttime breathing support qualify for mechanical cough assistance. But so many of us do not end up with this and have a dire need for it and cannot get it, and then develop pneumonia and sometimes worse. So peak cough flow is another indicator of impairment when it's less than 270 liters per minute, or your MEP if it's less than 60 centimeters of water. There were even studies done that showed that severe chest infections were predicted by vital capacity of less than 30% and peak cough flow of less than 160 liters per minute. So mechanical cough assistance, I cannot stress enough, be proactive about this. You do not want to wait until you need it. In the United States, most hospitals don't have this equipment. Some of the respiratory staff have never even heard of it. And if they do anything to assist with the accumulation of mucus, it's usually an invasive procedure, bronchoscopy. And it takes time to get this equipment in. On the slide where we showed that the two most common devices are Cough Assist T70, they stopped making that 2 years ago. And so it created a situation, and I'll move back to that slide so you can see that. It created a situation where there was a shortage, and many of us waited all through the latter half of 2023 and part of 2024, sometimes on a wait list to get the ABM respiratory byways cough system. That was really what kind of came forward as the leader once we found out that manufacturing ended for the T70. Support is supposed to end October of 2028 for the T70, but we're already hearing from folks that they're having difficulty getting the supplies for that device and struggles getting those repaired. So again, it takes time for insurance to approve this, time for the equipment to be delivered, and you want to have it in enough time to get familiar with it, comfortable with it, before you find yourself with a respiratory infection needing it. And if you're like me, then you'll use it every day because in my case, I just see so many benefits of that. We always like to talk about chest percussion when we talk about mechanical cough assistance, because a lot of people think these can be used interchangeably and that they are the same. What is featured on this slide is probably the most common brand. People like to call it the shaky vest. But the thing to understand here, and I pulled from medical literature a quote that points out that chest percussion and vibration can help to mobilize peripheral airway secretions, but they're not substitutes for coughing. And unlike for assisted coughing, they've not been shown to decrease pulmonary morbidity and mortality. So basically what it's saying here, if you have a weak and or ineffective cough, this is not going to make it easier for you to cough. Yes, it may loosen the mucus up and move it around, but if you still can't cough well, you're still going to be struggling. Some do end up with both pieces of equipment. They find that if they use the vest before their cough assist therapy, they need fewer repetitions with their cough assist, but it's more commonly used for children, and it really was developed for those with cystic fibrosis. If it comes down to you making a choice, you can have one versus the other. Hands down, I would say get your mechanical cough assistance, not your chest percussion, especially since today we have the high frequency oscillations that are available in those mechanical cough devices. So a suction machine is yet another item that you might want to have in your toolkit to prepare for respiratory infections. These are really helpful to have if you have thick, sticky mucus, which tends to happen during pneumonia. And sometimes the cough assist does a great job of moving it up, but sometimes it gets stuck in the back of the throat. And with a suction machine, there's a suction tip that's similar to what they have at the dentist called the Yankauer suction tip, and you can use that and get the mucus out of the mouth. It's something that's very important to have if you have a condition that involves bulbar muscle weakness, that weakness of the mouth muscles. So you can learn more about cough and NMD by going to our website and select the cough link there. There are a lot of articles that you can print out, share, use for that effort for medical self-advocacy to proactively get your mechanical cough assistance equipment. Lung volume recruitment, abbreviated LVR. It's also referred to sometimes as breath or air stacking. This is what I find virtually no one has heard about in our community, but it's a process where you stack one small breath on top of another small breath. You hold your breath between those and you just keep stacking breaths until your lungs are filled. It's a way to get more air into your lungs than you could do on your own. And this device that's pictured here, the AMBU bag, or sometimes referred to as the manual resuscitator, it's modified to have a one-way valve, meaning you couldn't use it for resuscitation, but that bag gets squeezed and it's connected to tubing and either a mask that covers the nose and the mouth, or it can be connected to a mouthpiece. And the bag is squeezed, it delivers the air, and the individual uses this as a form of exercise for their breathing muscles and their lungs. They may start out only being able to hold one breath, but over time, daily use of this, they stretch those muscles, and it's not a way to strengthen, but to stretch those muscles. If you're in a situation and you don't have mechanical cough assistance, you can use this to get a bigger, fuller breath to help you cough. And of course, you can probably see there's an overlap between the cough augmentation, mechanical cough assistance, and LVR. And that's because they both use the same lung insufflation strategies. They both are based on achieving maximal lung inflation, either by an air stacking technique, which we showed with the AMBU bag. We can also do that too if you have a portable home use ventilator and you have a multi-mode ventilator, or one that has multiple prescriptions that can be enabled. If you have mouthpiece ventilation set up on a volume cycled mode. So some folks do that with their ventilator, or of course the MIE device, which this one on the slide is another one that we're hoping is going to be available in the US. I think currently it's just available in European countries. So before we close out the presentation and look at your questions, I want to make sure that we delve into a little bit more about supplemental oxygen. This is oxygen that we would receive through a nasal cannula. For someone with weakened breathing muscles, when we increase the amount of oxygen that person is getting beyond room air, for us, because we generally have weak effort to move air into and push it back out of the lungs, it causes us to not be able to exhale the waste product of all that additional air, carbon dioxide, quickly enough. We all have what's known as the respiratory center in our brainstem. Some of us are more sensitive than others, but that respiratory center is what tells you to breathe when you stop breathing. Sometimes it can get confused when we're receiving supplemental oxygen, and it thinks that we don't need to breathe. We're getting enough oxygen. And so we see that the drive to breathe is slowed down. And sometimes it leads to respiratory arrest. And without breathing, that CO2, that waste product of all that additional air, it can build to dangerous levels in the lungs and the blood, known as hypercapnia. And in worst case scenarios, it can result in death, CO2 narcosis. This is what led to my sister's whole challenge with her ER visit. They did not understand neuromuscular breathing weakness, and they gave her hours of supplemental oxygen when she was already presenting with hypercapnia. So obviously this led, in her case, to respiratory arrest, and they were able to revive her, but it was just downhill from that point forward. So we created a self-advocacy tool, if you will, in the clinical considerations form. This is something you can go to breathewithmd.org, select our resources link, and the clinical considerations form can be downloaded and printed off. It's really just something to use to open a dialogue with a clinician. Maybe you're going for an MRI and you realize that maybe you'll be struggling to breathe while lying flat. And the first thing they're going to want to do is give you supplemental oxygen for that. But this allows you to basically explain to them that what may be okay for someone without neuromuscular disease can be a problem, can be a danger for those of us with neuromuscular disease. Folks like to use this and include in the notes section at the bottom their contact info for their NMD care team. And again, it's just an easy way to initiate that self-advocacy process. Our respiratory care information card works in a similar manner. You can go to our website and order this if you're in one of, I believe it's maybe 12 different countries that folks reside in, can get these for free. The great thing about this is on the back side of it, we have a QR code that you can scan, and it takes you directly to our oxygen caution page where you can learn more and find articles that you can share with clinicians to help them understand this, because unfortunately, even today, a lot in the medical community do not understand the danger of supplemental oxygen for someone with weakened breathing muscles. There are safe ways for you to receive it, though. You would want to have that bled in with your bilevel ventilation with appropriately enabled settings. I say that because we continue to see instances where people will be set up on mechanical ventilation and they develop symptoms that show either it's time to increase those settings or maybe those settings weren't really enabled appropriately ever. And the clinician will decide, let's just bleed in oxygen. But if they still don't have good movement of air into and out of their lungs, this can get them into trouble. This can lead to them having the opposite effect. It can make things worse. Another thing, too, is in the hospital setting, we hear of folks that are told that they're given so much oxygen that the clinicians are wanting them to reach 100% for oxygen saturation. No, we just need to be at 95%, somewhere around that, not above that. We find that when folks get so much oxygen that their saturation is higher than 95%, then they start to retain that CO2. Obviously, everybody's different and some are more sensitive than others. But if they check your CO2 level frequently, they can really use that to help guide how much supplemental oxygen is appropriate, maybe dialing that back, seeing that you could get more. There are times, when we have lung tissue issues through illness, maybe pneumonia or some sort of injury, that we need supplemental oxygen. So we don't want people to think that you can't use it at all, but you just have to be really careful about this. This is one of those areas that sadly we just see go poorly in a lot of cases. So in conclusion, Breathe with MD Inc., we're a resource for you. All of us live with neuromuscular disease or have a loved one who does. We're all volunteer led. Obviously, I shared our website multiple times. We're on Facebook. Our public page there is primarily used for educational posts. You can find us all throughout popular social platforms. our private support group, Breathe with MD support group. You're welcome to join that. Just be aware that we sort of have that semi-automated. And if you don't answer all those membership questions and agree to the group rules, it will kick your request out within, I believe it's an hour. So we see that happen all too often. And we do still have some accounts available for our Breathing Muscle Weakness 101 course. It's closing in the middle of November, but there's still plenty of time for you to get through all 8 of those lessons. I have seen people complete it in 48 hours. Average time is about 2 weeks. And then we anticipate bringing this back for its 3rd year next year in spring, and I've included my email. So if you have questions that you don't want to share here, feel free to reach out to us. And that is all I have slide-wise.
Excellent. Thank you so much, Andrea. Um, so starting out with the questions, if you have questions, please put them down in the Q&A section at the bottom of the screen. Before we get into the questions, I want to thank you for the medical alert card that you brought up. And I want to announce that the AMDA is also working on our own medical alert card that, with your help, thank you so much for that. And we are hoping to get that on our website very soon for our community. But let's talk a little bit about the assisted cough machines. You mentioned that they're no longer in production, correct?
That's the Philips Respironics T70 model. That's probably the one that most people have. So,
Okay. How much are comparable uh, devices, or how much would you expect if you were looking to get one to pay?
well, if you paid out of pocket, it's been a while since I've looked at those. Some have been successful at buying those on eBay. Buying one that has very low blower hours, that's going to be a critical thing, but I probably wouldn't buy a T70. I personally have one, and before they stopped manufacture of that, um, I was already getting concerned because mine was almost 9 years old.
Hmm.
We qualify for one through insurance every 5 years, so I had started the process to get the ABM respiratory um, cough system. So I would suggest, staying away from the T70 simply because at some point parts for that are going to become unavailable. But you're looking at thousands of dollars. It's going to vary greatly. I would say $4,000 to $6,000 probably to buy one outright, and that's pretty much why we all get them through insurance, and they're usually on a capped plan, meaning your insurance will cover it for so many months of rental. So you'll pay like a copay. Some insurances it's 10 months, some it's 13 months. So you make a monthly payment for that. And at the end of that time, that amount that you have to pay out of pocket caps, and then you own it. Your insurance pays the difference, or it's just all that's going to be paid to that durable medical equipment supply company. So then you own it at that point.
Okay. And to have insurance pay for it, you would need a provider order for that, correct?
Yes, yes. In fact, you have to have a face-to-face visit. Some are successful getting that ordered through their primary care provider. The challenge there is they aren't always informed about, what qualifies the individual. So that's part of why we pointed out those guidelines, what um, denotes cough impairment. But they need to make sure that they document that you have a neuromuscular disease. You don't even have to have an exact diagnosis, just that you have neuromuscular disease and you have an impairment of movement of your chest wall muscles, such that you don't have the ability to effectively cough and clear the airways. Most of the time, insurance realizes that it's cheaper to pay for this equipment than to pay for all the hospitalizations related to repeat episodes of pneumonia. So,
Okay. Awesome. Do you know of any exercises or respiratory training programs that can help strengthen the breathing muscles?
So there's been quite a bit of research about this, and there was an article we shared in our monthly newsletter, I'd say a couple of months ago. And basically, the conclusion that they arrived at was that more research is needed on this. There's not been anything to date that's proven that we can strengthen those diseased respiratory muscles. We can stretch them, though, and that can make a great impact. That's what I've done with using my device daily. In fact, for my diagnosis, there was a study the year that I went to the NIH to get my correct diagnosis. They were doing a study on cough augmentation therapy with my specific disease and trying to show whether there was a benefit, a long-term benefit to that stretch. And, I feel like there is for me, but these cough assist devices, I like to say it's the device that everybody loves to hate. It often sits in a closet collecting dust, but I'm one of those people that I want to avoid the hospital so badly, and I've just seen the benefits for me in using it. In fact, I would, before I used it every day and used it every day for about a year, I would have a time during the day, mid to late afternoon, where I would feel a tightness in my chest. And for a long time, we thought that was asthma. We
Mm.
thought that I literally had asthma in addition to neuromuscular breathing weakness, which is restrictive, and asthma is an obstructive condition. So we usually don't see, obstruction with restrictive airway conditions like respiratory involvement has. But I found that I could just go to that cough assist device, use that for a few repetitions, and that tightness would go away. Similarly to, the way that we stretch other muscles in our body. So I really feel like in my case, those muscles for me do get contracted, just like those that are in the bend of your elbow and behind your knee. So by stretching them, I'm just constantly working to prevent contracture of those.
Awesome. And one more thing before we conclude here. If you could give advice to someone who may suspect that they may need to start non-invasive ventilation or a cough assist machine, but are maybe in denial of that, what advice would you give someone?
I would say don't wait. It's too risky. It's not going to go away on its own, and most of us find that it's not what we thought it was. It's not as bad as we thought it was, and particularly with our Breathe with MD support group, there are so many people going through the same thing that peer support is available for you, and it will get you through that. It is, I know it's scary to think of not being able to breathe well, but it's just one of those things. It's like if we need an assistive device for mobility, we get it. We see the benefits of it. It's the same way with these breathing muscle aids with mechanical ventilation and mechanical cough assistance. We definitely get past those initial negative feelings once we see how much better we feel and what a difference it makes in our quality of life.
That's wonderful advice. Thank you so much. And with that, this concludes today's AMDA webinar. Thank you so much, Andrea, for that wonderful presentation. And thank you everyone for participating, and we'll see you next time.
All right. Bye.
Have a great day.
Thank you. You too.